So good afternoon to everyone. The topic for today is collection of specimens for microbiology laboratory. First and foremost, the basic principle is that if a physician or clinician is dependent upon the microbiology lab data for helping to save his patients, then the one who collects the specimen may determine the course of the patient's recovery. So, as an example, I would like to show you two forms with a single sample that has been collected from a patient, and the test on reads pericardial fluid as well as pleural fluid. Now, on a half day Saturday, we received the sample in the laboratory with two forms and clue as to whether it was a pericardial fluid or a pleural fluid. On calling up the concerned resident on the CUG, we were told that he has absolutely no idea and someone else has used his login and password, which is the most common query or answer that we get upon inquiring about that sample or patient. And then we were given about one or two other numbers, but we still could not find out who had collected the sample and which one was, whether it was a pericardial fluid or a pleural fluid, and both forms had to be sent back to the ward. So specimens submitted for microbiological testing require proper handling from the time of collection through all stages of transport, storage and processing, and they should be collected in such a way that contamination by indigenous flora is minimized. So the basic principle for collection of sample for a microbiology culture laboratory is that there should be least contamination and strict asepsis. Now, what are the few important questions for a clinician before collecting a sample for microbiology investigations? The first is, are you suspecting an infection? If there is an infectious etiology of maybe the fever that the patient is having, then you should consider an investigation for culture. If so, then whether it is a bacterial, a viral, a fungal, mycobacterial or parasitic infection, which tests are your priority? After that, when to collect the specimen? Is there a particular timing when a blood culture should be collected or a urine sample should be collected? How to collect the specimen? Has the specimen been taken from a normally sterile body site, for example, cerebrospinal fluid or blood culture? Am I choosing the correct container? Because we have specific types of containers for various samples. Example, blood culture bottles, sterile white mouth bottles for urine and sputum, etc. And why do I have to send the specimens to the laboratory without any delay? Now, all this information derived has an impact on the diagnosis of infectious diseases, antibiotic prescribing, formulation of antibiotic policy, as well as infection control measures such as methicillin-resistant Staphylococcus aureus or to contain metallo-beta-lactamase producing gram-negative bacilli. So, as we are all, I think, familiar by now with the hospital information system, and there is a window which says CPOE, and that is for computerized physician order entry, from where we can order various services and go to the various departments for investigation. From the drop down menu, we can select it as microbiology and then come to the various sections. Now, before taking a printout of the form or raising a form, we should be very clear to fill in the test on field. It is very important to tell us whether the sample is pus, a urine, a sputum, a swab, tissue bits, biopsy sample. That is a mandatory field because it gives us a clue regarding the nature of the sample and the site of infection. Then the second important note is that always raise forms for both microscopy as well as culture. A microscopic examination by staining, either a gram stain or an acid-fast bacilli stain or a fungal stain, gives us a clue within half an hour or 1 hour or maybe few hours about the nature of the infection, and it can very importantly help us in starting the empirical antibiotic coverage. So please remember to raise forms always for both microscopy as well as culture. Now, which divisions of the microbiology laboratory do we have to send the samples to? For example, if a patient is presenting with features of urinary tract infection, then we have to send a urine sample to the bacteriology lab. Similarly, other divisions are mycology for diagnosis of fungal infections, parasitology, serology and microbial immunology as well as virology, tuberculosis lab, that is mycobacteriology, and hospital surveillance as well as infection control. Now, what are the, I'll not go into very much details about the tests that have to be raised, but by and large, we have to raise microscopy as well as culture. In the bacteriology lab, for blood cultures, you have to remember that we have got a set of blood cultures, both aerobic as well as anaerobic, for culture and sensitivity for patients who are in sepsis or bacteremia. There is another test which is the automated bacterial identification and sensitivity testing, which tells us about the minimal inhibitory concentration. This is especially important for patients who are in the critical care ward, and monitoring of treatment or dosing of the drugs can be important, can have an important impact on the outcome of treatment. Then in the mycobacteriology lab, we have microscopy and cultures, both routine as well as automated. We have the gene expert MTB RIF assay, which can tell you within 2 hours or 3 hours whether the patient has Mycobacterium tuberculosis infection. This is especially good for pulmonary tuberculosis with sputum and bowel samples, and it will also give us an idea regarding the sensitivity to rifampicin, whether it is rifampicin sensitive or it is rifampicin resistant. So it gives us an idea regarding the multi-drug resistant status of the patient. Now the genotype, MTB complex genotype assay is a line probe assay which not only tells us about the presence of Mycobacterium tuberculosis but also gives us an idea to rifampicin as well as isoniazid. We also put up second line drug resistance testing by molecular method by line probe assay to the fluoroquinolones as well as aminoglycosides. Then there is a real-time PCR for MTB as well as microscopy for M-leprae. We do the slit skin smear for leprae also. We have the parasitology lab which deals with microscopy for malaria and microfilaria parasites, stool microscopy, routine culture for stool, some ELISAs, antigen detection tests for plasmodium infections and microfilaria. The cryptococcal antigen agglutination test is an important test that is performed in mycology lab, apart from microscopy and culture, as well as antifungal susceptibility by the diffusion method. Important tests in serology and virology include ELISAs, torch test for dengue, HIV, Vidal, measles, and of course now the COVID testing. Please remember, do not raise multiple tests on the same order number, because usually we require separate forms for doing our own lab logins and maintaining lab numbers. So it is best if you raise one test on each form. For example, if you have to, microscopy and culture can be raised on the same form, but if there are investigations from different sections, then it is better that you raise separate forms for each section. Do not raise anaerobic cultures for sputum, tracheal aspirate and urine, because the rate of anaerobic flora or anaerobic bacteria causing these infections is extremely rare. Microscopy should never be raised for blood culture samples or CVP tip samples. Always remember to add sample in the test on window as well as the diagnosis of the patient. Use the order remarks section for additional comments, and if you want to opt for MIC testing, then it is always good for very sick or septic patients. Now, volume of the specimen. So the first principle for collection of sample in the microbiology laboratory, as I mentioned, was asepsis, or least contamination from the microbial flora. For example, if I am collecting a blood culture sample, then I have to make sure that the skin is aseptically cleaned. Or if I am collecting a urine sample for culture, then I have to educate the patient regarding the value of a clean catch midstream urine sample. Or if I am doing a lumbar puncture for CSF, then I have to take absolute aseptic precautions and avoid any contamination of the sample. So the first very important principle for collection of microbiology sample is strict asepsis and least contamination by the skin flora or the environment. Now, the second most important principle is volume of the specimen. It should always be kept in mind that larger the volume of the specimen, more sensitive the culture becomes, because there are certain number of bacilli per ml of the sample that are required for culture to come positive. Culture anyways is always more sensitive than any other diagnostic, even molecular tests. And plus, culture is a proof of presence of the organism, viable organism especially. So always try to aspirate samples in syringes, collect as much volume as possible. Avoid collecting samples on swabs or sending few drops of fluid. Volume is especially crucial for blood cultures and mycobacterial cultures, especially from cerebrospinal fluid and urine. Apart from this, what are the other important documentation that have to be present on the form? The date and time of specimen collection preferably, the diagnosis and reason for specimen collection, any antibiotic history, and of course the other details regarding the raising of the form, from which ward the person who ordered the investigation, etc. Always remember to collect a sample before starting the empirical antibiotic therapy. This is because we all know that antibiotics will kill the organism or decrease the count of the organism, and the possibility of culture becoming positive becomes less. So maximum volume of sample that can be drawn, and before starting empirical antibiotic therapy or any kind of treatment. Now, what are the samples that we usually collect for culture? Pus, such as drains, diabetic foot ulcer pus, bile, PCN fluid, pleural fluid, CSF. These are the kind of various samples that we get in our labs. Urine, blood cultures. In pulmonary samples, we may get sputum, tracheal aspirates, ETTT, BAL, etc., and stool samples. Now, what we do is, even if you do not raise a form for microscopy, a gram stain is always performed on the sample to get an idea regarding the presence of pus cells. Not only pus cells and the type of organism that may be present, it could be gram positive, gram negative, fungal elements, or acid fast bacilli. By and large, these are the major organisms that we look for during a wet mount or a gram stain. Prior to a gram stain, even a wet mount can be performed on samples. So a KOH mount, for example, in mycology lab is important. A urine wet mount by direct microscopy under a cover slip, some amount of the sample will give us an idea regarding the presence of pus cells and the possibility of infection. So microscopy, either by a wet mount or a stained method, will give us an idea about the quality of the specimen as well as the presence of infection, whether in terms of pus cells or pathogens. Then culture. We routinely culture the organisms in bacteriology on routine culture plates, or we have got specialized media in various sections to culture the pathogens. So the laboratory diagnosis of an infectious disease begins with the collection of a clinical sample for processing in the laboratory, the right one collected at the right time, transported in the right way to the right laboratory. So the sample has to be labeled properly with the name, the registration number of the patient. It has to be collected at the appropriate time. Any delay in transport has to be avoided. It should be transported as soon as possible. In fact, it would be better if within 1 hour or 30 minutes, especially with precious samples such as CSF, cerebrospinal fluid. Where the patient is very sick, a gram stain can be very useful in starting the empirical antibiotic therapy and getting an idea regarding the etiology of the meningitis or the encephalitis. Then, before, as I emphasized, before the administration of antimicrobial agents and with strict aseptic precautions which prevents the contamination of the specimen with normal flora of the body. Tissue fluids are always superior to swabs and maximum volume should be collected. Now there is one very important point which I would like to mention over here. We should always notify the microbiology and pathology labs when both culture and histopathology are needed. This is especially important for biopsy samples, and many times these samples are precious because they have been obtained after interventional radiology. So the basic difference is that the sample will be put in formalin if it has to be sent to the histopathology lab, while the sample has to be put in normal saline if it has to be sent for culture. So many times, you know, the new residents who join in, they are not aware of this fact and they have to be told and guided that coordination between the microbiology as well as the pathology labs has to be done, because if you send or put all of the sample in formalin, then the organisms will die out and we will not be able to process it for culture. So better is to send a single sample first to the microbiology laboratory and then have it divided there. Or if you are dividing it at the site of sample collection, then you have to remember, for example, if it is an intraoperative specimen, if it is being done in the OT itself, then you please remember to divide one sample for culture in saline and the other sample for formalin in histopathology testing. So a single sample completely should not be placed in formalin at all. What are the other basic rules that have to be followed? It should be in a sterile leak-proof container. For fluids in syringes, example, when you are draining an abscess, then in the era of universal precautions, HIV and hepatitis B, the needle should be removed and replaced with a cap. Always remember that you should never refrigerate CSF or blood cultures and specimens for anaerobic culture. So if there is a delay in transport of cerebrospinal fluid or blood culture samples, then the containers or the bottles should be left at room temperature. If you have an incubator, then it is best to put the sample in the incubator. We have a 24/7 stat lab facility, 24-hour lab over here. So there is no issue, but if at any time in the ward, if you are not able to send the sample at any time to the laboratory, then you should never refrigerate CSF or blood culture. The reason now is that there are few organisms which are very fragile and at cold temperatures they will die out and we will not be able to retrieve them on culture. So always arrange for immediate transportation. Now, what are unacceptable specimens? Unacceptable specimens are those that are unlabeled or maybe multiple forms with one sample and with different, you know, both the samples are different. Specimens received in leaking, broken or cracked containers, those with apparent visual contamination that have been left for a long time and they are being sent after a lot of delay. Unpreserved samples received more than 12 hours after collection, and inappropriate samples. For example, avoid sending a throat swab for automated bacterial culture. Automated blood culture or bacterial culture is appropriate for blood, for sterile body fluids other than urine and CSF. So throat swabs, urine samples are not suitable or appropriate for automated culture testing. Then coming to the collection of specimens as per the site of infection or the clinical syndrome. So they are bloodstream infections, patients in sepsis, central nervous system infections such as meningitis and encephalitis, urinary tract infections, upper and lower respiratory tract infections, gastrointestinal tract infections, and wounds and skin and soft tissue infections. So bloodstream infections, I'll not go into the details of that, but I'm sure all of us are familiar with the triple lumen CVC catheter. Usually hematogenous route is the spread for bloodstream infection, especially the extraluminal spread where there is contamination by the skin flora. So the most common is the extraluminal infection. Now, what is a blood culture? A blood culture is a test in which blood is injected into bottles containing culture media to determine if the patient has microorganisms in his bloodstream or there is bacteremia or septicemia. So as you can see, though maybe most of you are not familiar with the routine culture bottles, however, we have, the best culture to avoid least contamination are the automated bactec bottles. We've got 3 color coded bottles. One is the aerobic vial, the blue colored one. There is the orange colored one is the anaerobic vial, and most of you do not know that there is a third vial which is available, which is the pediatric vial, and it has got a pink cap. So there's a Peds Plus vial also. Though there are, fungal culture bottles that are available, however, we do not have them at our institute over here. But for candida infections, the blood has to be inoculated in the aerobic culture vial only. So what is a contaminated blood culture? Inadequate skin preparation or lack of universal precautions, especially hand hygiene, leads to a contaminated blood culture. I'm not sure if I have time. I'll run this collection of blood culture sample video at the end of the slide. If there is time, you can see it. Now in sepsis, what is the number and timing of collection of culture? 2 to 3 cultures from separately prepared sites. So always remember that a blood culture has to be prepared as a set. Always collect 1 aerobic and 1 anaerobic sample. For an adult, the minimum volume should be 10 ml in 1 bottle. For bacterial endocarditis, patients who are not on antibiotics, a single blood culture will be positive in 90 to 95% of cases. However, it is best to take 3 to 4 separate blood collections that detects the continuous bacterium. Now, there is an entity which is known as CRBSI. So, what is CRBSI? CRBSI is a catheter-related bloodstream infection. Now, this older definition, which was more stringent, has now been replaced by CLABSI, which is central line associated bloodstream infection. So, if you have to determine that if the CRBSI or the central line or the CLABSI was due to the contaminated catheter tip, then we can do a semi-quantitative culture in which the distal 5 centimeter portion of the catheter is rolled and a semi-quantitative culture is done. And if we recover the same organism from the tip of the catheter as well as the blood culture, then we are sure that the source of infection was the catheter. Now, as I have mentioned before, coming to the transport of blood cultures without any delay, these bottles should never be refrigerated, preferably kept at room temperature or in an incubator. In fact, these bottles have got a shelf life written on them. Even when you are not collecting, these can be left at room temperature. The best part about these culture bottles is that you need not refrigerate them. So the common query usually is that when I get the bottle issued from the laboratory, do I have to keep them in a refrigerator till the time the sample is collected? So no, these bottles can be kept at room temperature very easily, and all you have to do is collect the sample of the patient, and aseptically you have to put it at least 10 ml of blood in each bottle. Similarly, a bone marrow collection can be done, though most of the time what happens, we do not get bone marrow. We get a huge volume of blood that is drawn by especially in disseminated cases of tuberculosis, or if a diagnosis is needed, then usually we do not get bone marrow samples because bone marrow will be straw colored and hardly 1 ml or less than 1 ml we can draw. We get large amounts of blood samples. Now coming to the diagnosis of urinary tract infections, there are 3 ways in which we can get samples or collected samples to culture. First is the clean catch midstream urine sample. The second is the catheterized urine, and the third is the suprapubic aspiration of urine, which may be done in children. So clean catch midstream urine, the patient has to be educated, and after some few milliliters of the urine have passed, then we have to collect the sample in the sterile wide mouth container. Now, 3 consecutive first morning whole urine samples are recommended for culture of tuberculosis. So, with genitourinary tuberculosis, we have sterile glass bottles, which are larger bottles than the routine plastic ones, wide mouth screw cap bottles. And first morning urine sample for 3 consecutive days is recommended. This is especially important for students from nephrology and urology. You have to remember that please tell the patient raise 3 forms in which you write day 1 urine or urine 1, urine 2 and urine 3, and 3 first morning consecutive collections. At least 200 to 250 ml of urine has to be collected in wide mouth glass bottles which are available from the lab for culture for tuberculosis. Then these are the usual containers that we have: sterile, leak-proof, wide mouth containers. We can use a few preservatives, but generally the urine samples are processed in the lab in the forenoon as well as the afternoon. So within 1 hour or 1.5 hours, the culture is put up. Then I told you about the catheterized urine. Never collect urine from the bladder. Please remember that the catheter has to be clamped, and with a syringe you have to aseptically aspirate the urine from the tubing. Foley's catheter tips are unsuitable for culture as they are contaminated with the urethral or colonizing organisms. So always puncture the collection port aseptically, and first you have to clamp the catheter below the port and allow the urine to collect in a rubber tubing that has been cleaned with 70% alcohol. After some urine collects in it, then you have to send about 10 ml in a sterile wide mouth container. Never collected from the collection bag. Suprapubic aspiration may be useful in pediatric patients. Now for CSF specimens, we know that it has to be submitted in 3 separate sterile tubes for cell count, for culture, gram stain as well as for protein and glucose. Other CNS samples which come maybe brain abscess or biopsy. So this is, we are all familiar with the spinal tap technique, which has to be performed very aseptically. For cryptococcal meningitis, we have a direct detection of cryptococcal antigen by the latex agglutination test, which is highly sensitive and specific. And in fact, it is much better than microscopy itself, though of course the presence of capsulated yeast-like budding yeast-like cells confirms the diagnosis of cryptococcal meningitis. Then we have PCR and other molecular methods. Always remember that CSF should never be refrigerated, and concomitant blood should be obtained for blood culture if you are suspecting that the patient has acute bacterial meningitis, because there is a bacteremia also that is always associated with bacterial meningitis. But volume of CSF that is recommended is, though of course a large volume has been written for TB culture, but it is best if you send us as much sample as possible in volume. If to avoid contamination, it is better that you raise the forms for various sections. If suppose you want to send CSF for both fungal as well as TB culture, then please let us divide the sample aseptically and we will send it to the various sections. Then upper respiratory tract infections specimens to be cultured are throat swab, nasal swab, nasopharyngeal swab, sinus aspirates or tympanocentesis fluid. So the most common ones are nasopharyngeal swab, throat swab, and for which the transport medium for the virus is available, and these are the various kind of swabs or the kits that are available. I won't go into the technique of throat swab collection. However, you can just depress the tongue and then sweep it completely, the swab, across the tonsillar areas and any inflamed areas. And then after doing a thorough sweeping, you have to withdraw it and send it as for culture. For a nasal swab, which in the times of COVID, for COVID testing, a nasal swab is much superior to a throat swab. Then what you have to do is a sterile swab has to be inserted into the nose till a slight resistance at the level of the turbinates is met, and then the swab has to be rotated, and then you have to repeat the procedure on the opposite side. Similarly, a nasopharyngeal swab may be collected where you pass the swab through the nostril till it reaches into the nasopharynx. For lower respiratory tract infections, we have sputum samples obtained by deep coughing or expectoration, especially for tuberculosis. So lower respiratory tract infections, make sure that you educate the patient that they do not spit saliva. And if a lot of sputum is not coming, then a patient may take steam inhalation or hypertonic saline. Then deep coughing they may be induced sputum sample, deep coughing may be done, and we'll get adequate samples. Transtracheal aspirates, ETTT, BAL, and lung biopsy. The best specimen for sputum collection is the best time is early morning. And if suppose you are not able to transport the sputum sample immediately, then it may be put in a refrigerator. Gastrointestinal samples, upper stomach and duodenum, biopsy samples may be sent, lower GI tract, stool sample, or even rectal swabs may be collected. Now, rectal swabs may also be collected for surveillance purposes. The test, parasitology, you can go to the parasitology section, and a routine OVA and parasite examination may be look for stool for opportunistic pathogens, antigen detection, and C. difficile toxin ELISA is also available. Stool samples should not be contaminated with urine, and 1 to 2 gram is sufficient. So this is how a stool container, it is actually a green colored one container that is available in the lab. It has a small spoon in it, and you just have to pass the stool sample in it. In the lab, we withdraw the spoon and use the sample for processing. A rectal swab, as I said before, may be also obtained. For genital tract infections, cervical specimens, or usually what we get is a high vaginal swab that is collected. So conclusion is, accurate and cost-effective microbiological test results are possible only when specimens are collected, transported, and stored properly. When proper procedures are followed, cultures of specimens are less likely to be contaminated and more likely to yield pathogens. There is easier interpretation with reduced healthcare costs. Thank you so much for your kind attention. If there are any questions, I can take them.